Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you're probably looking at this image saying, I recognize that, and I bet you do. This is Gottron's papules associated with dermatomyositis. We're going to be talking about this and much more in this presentation on skeletal muscle pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material, but you already know that because you're ahead of the game. Now, skeletal muscle pathology is the study of diseases and disorders that affect skeletal muscle. In this section, we highlight non-neoplastic entities that affect skeletal muscle, which include important conditions that you must know, such as dermatomyositis, polymyositis, muscular dystrophy, both Duchenne and Becker, as well as neuromuscular junction disorders like Myasthenia Gravis and Lambert-Eaton Syndrome. For neoplastic lesions that may affect skeletal muscle, please refer to soft tissue tumors pathology. Now, dermatomyositis. What is that? Dermatomyositis is an inflammatory disorder of the skin and skeletal muscle. Here we have a picture of Gottron's papules on the finger joints associated with dermatomyositis. Dermatomyositis is characterized by muscle weakness and Gottron's papules, which is a pathognomonic distinctive skin rash. The exact cause of dermatomyositis is unknown. Some cases of dermatomyositis are associated with carcinoma, for example, gastric carcinoma. Clinical features of dermatomyositis include bilateral proximal muscle weakness. Distal involvement can develop latent disease. Rash of the upper eyelids, known as a heliotrope rash. Gottron's papules, which are red papules on the knuckles, elbows, and knees. And malar rash. Laboratory findings of dermatomyositis include increased creatinine kinase, positive antinuclear antibody, ANA, and positive anti-Jo1 antibody. In regards to the histology of dermatomyositis, that will show perimysial inflammation with perifascicular atrophy. And note the inflammatory infiltrate will be CD4 positive T cells. To the right here, you can actually see the micrograph of dermatomyositis. Do you see the inflammatory infiltrate in a perimysial distribution? Corticosteroids are used for the treatment of dermatomyositis. Do you recognize what's going on in this image? Gottron's papules. More Gottron's papules, this time on the elbows of a person with the juvenile form, or a juvenile person. Gottron papule. Now, dermatomyositis. Here we have an x-ray of the knee in a person with dermatomyositis. And we can see the calcification associated with dermatomyositis, the Achilles tendon. And here we have some skin histology showing a hematoxylin and eosin stain with perivascular and interface lymphocytes and dermal epidema or edema and mucin, which are characteristic of dermatomyositis. An Alsatian blue stain helps highlight some of that mucin that's present in B. Note polymyositis. Now, polymyositis is an inflammatory disorder of skeletal muscle. And just based off of this image on H&E, it looks different than what we've seen in prior slides, right? Here, the inflammatory infiltrates occurs in holes in the muscle cell vacuoles and deposits of abnormal proteins are present within the cells and in filamentous inclusions, hence the name inclusion body myositis in this particular condition. Now, polymyositis is a rare condition that weakens the muscles on both sides of the body. Clinically, polymyositis resembles dermatomyositis, but the skin is not involved. Histology of polymyositis will show endomysial inflammation, CD8 positive T cells with necrotic muscle fibers. And here we can see various panels showcasing various muscle fibers. In A in particular, we see the microsomal prostaglandin E synthase, right? These are stains that you will not be asked about. Now, muscular dystrophy. Muscular dystrophy is a degenerative disorder characterized by muscle wasting and replacement of skeletal muscle by adipose tissue. To the right here, we have a cartoon showcasing muscular dystrophy in the affected muscle, the right. The tissues become disorganized and concentration of the dystrophin gene, which is an important protein, is greatly reduced. The main types of muscular dystrophy that you need to be aware of are Duchenne muscular dystrophy and Becker muscular dystrophy. Now, there's an easy way to remember this. Remember that Duchenne's is disastrous, worse prognosis, and Becker is better prognosis. Muscular dystrophy is caused by abnormal dystrophin. The attachment of the muscle cytoskeleton to the extracellular matrix is made possible by dystrophin. Mutations in dystrophin often occur spontaneously, and a high rate of mutation is predisposed by a large gene size. Duchenne muscular dystrophy is due to deletion of dystrophin. At around the age of 1 year old, patients with Duchenne muscular dystrophy may develop or already have proximal muscular weakness that progresses to involve distal muscles. Calf pseudohypertrophy is characteristic, right? It's a characteristic finding of Duchenne muscular dystrophy. Lab findings of Duchenne muscular dystrophy may show elevated lactic acid and elevated serum creatinine kinase. The heart is typically involved in Duchenne muscular dystrophy. And in Duchenne muscular dystrophy, death typically results from cardiac or respiratory failure. Becker muscular dystrophy is due to mutated dystrophin. Becker muscular dystrophy clinically results in milder disease compared to Duchenne muscular dystrophy. Now let's switch gears here and talk about neuromuscular junction disorders, such as Myasthenia Gravis. Myasthenia Gravis is a chronic autoimmune disorder due to autoantibodies against the postsynaptic acetylcholine receptors at the neuromuscular junction. To the right here, we can see a characteristic finding in a patient with myasthenia gravis. Now, myasthenia gravis is more commonly seen in women than men. Clinical manifestations of myasthenia gravis include muscle weakness that worsens with use, muscle weakness that improves with rest, ptosis or lid lag, and diplopia. Myasthenia gravis is associated with thymic hyperplasia and thymomas. A thymectomy may improve symptoms. Treatment of myasthenia gravis are anticholinesterase agents, which help alleviate symptoms. Here we have a picture of a patient showcasing different states of their condition. The photograph of a person showing right partial ptosis in the left picture, and the left lid shows a compensatory pseudo-lid retraction because of equal innervation. And in the right picture, this is after the edrophonium test. Note the improvement that's occurred. And here we have a CT scan showing a thymoma in the red circle, which is associated with myasthenia gravis. Now, Lambert-Eaton Syndrome. Lambert-Eaton Syndrome is due to antibodies directed against presynaptic calcium channels of the neuromuscular junction. Lambert-Eaton Syndrome may arise due to a paraneoplastic syndrome, most commonly due to small cell carcinoma of the lung. Lambert-Eaton syndrome is associated with impaired acetylcholine release, right? Because it's at the presynaptic terminal. Firing of presynaptic calcium channels is required for acetylcholine release. Clinical features of Lambert-Eaton syndrome include proximal muscle weakness that improves with use. Acetylcholinesterase agents do not cause any improvement of the symptoms due to Lambert-Eaton syndrome. Lambert-Eaton syndrome may resolve with resection of the cancer if the cancer is the underlying cause, as we can see here in this chest x-ray showing a tumor in the left lung associated with Lambert-Eaton syndrome. And with that, you completed another presentation. You're well on your way to success. You're doing such a great job. You make me proud. You're going to get 100%. You're going to rock it. You're going to do great. Till next time, I'll see you later.